This app has been brewing in my mind since the Gate app 3 or 4 years ago. So we finally pulled together a team that I thought these are the guys that we can really pull this off. And so we presented some of this in 2018 in a presentation about creating and sustaining behavior change using apps to teach movement. And we are currently gathering more data in the Motion Lab. So let me give you a glimpse here. I'm very curious to see your thoughts about how we have tried to build upon the Gate paradigm, the Gate movement analysis paradigm. So you can see, okay, I'm going to click on the functional movement app here. And the app opens. And now you have a choice of some common functional movements that Christina teaches in year one, someone teaches in year one, which I think we need to do as well. I imagine this to show up in your early range of motion kinese class. So here's forward bend, and here's 3 types of forward bends. As we've been looking at the data, watching these, we've been capturing all of these subjects and looking at some differences and trying to quantify them in at least, you can quantify them so small that we'll never be able to get our heads wrapped around it. Or you can pick some relatively reasonable strategies that we see commonly and then try to help students and ourselves be able to observe it reliably. And so again, we created the learn phase in which you'll see the exact same breakdown as Gate. So if you go to the phases of forward bend, and this is hip-lumbar, meaning the optimal hip and lumbar ratio, we basically observed, we basically stopped the videos at certain points and said, I think this really is the initiation of forward bend, and this is what we would tell students to look for. Begins with the anterior movement of the trunk and ends when the shoulders are anterior to the hips. And so again, it's in static, so students will have time to process these phases. And here's termination, right? The passive structures become taut. This helps me explain why we have ligament injuries, muscle injuries when this lever arm is so long. And we can move into muscle, here's actually range of motion. So we have lower thoracic, lower lumbar, and hip. So what I think is really cool here is to be able to visually show a student when forward bend begins, you can see that motion is initiated at all the joints. There's nothing wrong with that. In fact, it's quite safe. But what you see is that the hip joint, which is designed for large arcs of motion, is already at double the amount. So it's moving at a rate that is double and eventually 4 times and eventually 5 or 6 times, right, that of the other joints. That is a powerful conversation to have. Any thoughts about that? I mean, we've captured, motion capture of, we thought, well, we have lower lumbar, we have mid lumbar. We put markers on lower, mid, and kind of pelvis. And then we have thoracic. And in fact, lower lumbar and upper lumbar, they move different too. And there's a lot of variability. So it's interesting. We're trying to figure out, should we just aggregate lumbar as one aggregate finding and display it in a meaningful way? Though I think representatively, if you're thinking about how do I teach this to a student, too many little segments is just not meaningful from a visual analysis standpoint. So from here, we could say, you know what, guys, you should see a high rate of hip flexion movement compared to lumbar movement. If you're seeing a high rate of lumbar movement, these guys are probably going to stress some structures that will now nicely tie to my orthopathophysiology related to ligament, lumbar sprains and strains. So here is actually muscle activity. So we took glute max, erector spinae, and biceps fem, and we said, hey, does it make sense that as the trunk gets longer, that the erector spinae starts going up in activity? The glutes and hamstrings are trying to slow you down as you're coming into this controlled fall. And wow, when we're at termination, the muscles are beginning to switch off. They're changing in direction, really. They're going from eccentric to concentric. And that means a lot of my passive structures, my disc, my ligaments are all being loaded. Could you see why someone's movement strategy like this would potentially lead to some tissue injury? I think that is, to me, how we begin to build the bridge between human movement and tissue pathology.
Mm-hmm.
So, again, we sat together and tried to create some critical events that are actually meaningful and observable. And of course, Chris Sabelski and her team, and Hayes, and out of St. Louis University, they are very vested in looking at how do we cue patients to change their movement, which ultimately will change stress loading, shift stress loading to different structures. So here is the critical events for forward bend. So that's just a glimpse. Now the cool part is, just like the Gait app, when you're ready, it's time to go to analyze. So you can look at him from different views. But because I've trained your eyes to see some things, I can switch to different views, front view, or we can go straight to range of motion. So again, part of my mind thinks about how do I keep the student engaged long enough and actually evolve from static pictures in a way that eventually turns them into someone who can observe human movement. So you see, we've tried to mark, here is termination of return from bend. And then here's EMG. Now, we're not claiming to know what normal is. This is a case of what someone looks like during a forward bend movement. And we're going to have 3 different options as a way to begin this idea of teaching people movement. And I think what's cool, if you see in return from bend right about here, so right about here, so the muscle activity is now reversing. And as the trunk is beginning to initiate into return from bend, it's cool to be able to see that the hip muscles are what kick it off. So instead of leading with their head and using their erector spinae where the trunk is longest, in fact, the hips kind of kick the motion off, and then the erector spinae begin to activate while the lever arm begins to shorten, right? It's kind of like getting a car going. It's always hardest from 0 to 30. Any thoughts about this? So we are, as you can see, we film forward bend, return from bend, sit to stand. There's actually quite a bit of literature related to sit to stand, squat, lunge. The very things you'll be teaching Christina will all be built in this same format. So that we could imagine in your range of motion MMT class, guys, we are now going to look at the hip joint, muscle testing, and range of motion. But first, I want you to look at a few common functional activities. And
this is James. The comment on the chat is very, very positive. But what have you done for me lately? How about peds? And the question, and I forget who S. Ross is.
Yeah, I think
Sandy. Is there standardization enough of pediatric movement? Or I mean, I watch kids move on a playground, and it's like chaos. And so, or what? In what context are you thinking of pediatric?
So. From the pediatric standpoint, we are about to release the developmental milestone app where we film the same baby, pretty much the same baby, for the first 12 months of his life. So you can begin to see the baby's change and the movement strategies as the baby kind of grows. Our next phase is to capture a bunch of pathologic babies. Of course, it's tricky, as you know. With any patient capturing, it's tricky. So we have created a list of babies and that we want to capture. And we're going to start bringing them in and trying to give students and faculty a way to, like, I don't know, like you said, there's probably a million different ways that babies move different. So it's really valuable to teach them what we think is normal development, so to speak, of which these so-called abnormal videos can be used to contrast, right? Normal is only really meaningful when you can see what the alternatives are. And so I think that's what we're going to try to do is after we release Developmental Milestones app, we'll then start capturing babies doing functional tasks in various dysfunctional ways and hope that that will allow us to create conversations that faculty can now say, what do you see that's different compared to what you would have expected in a baby sitting upright? Or when the baby is grasping across midline, what do you see in this baby that they're not doing? What can you do to improve that, to facilitate that? So I think that that's where we're going to head. It's laborious. It's very costly because we pay the parents to bring their babies in, and so that's what I envision. I don't know if there are any other thoughts related to that. Anybody else have any comments? And this ties to neuro as well, right? So now that we've taught people how generally people sit to stand, what does this look like in the neurologic population that has, pathology?
Mm-hmm.
Any other comments, Jim? This is a good. I only have a couple more slides here to show, and then we're really, it's, to me, we're just back wide open to discussion about what you as faculty are hoping to see, or how you might contribute to the evolution of what we're doing.
Yeah, I think you're taking the template which you established probably with the gait, which we're very comfortable with as educators. I mean, we taught gait a lot, and now we're realizing, boy, it's power in now the other venues of physical therapy that we have to teach. And the question is then, how do we get this into an already impacted curriculum? And that's the challenge that I'd love to have conversations with other instructors to see what are some strategies to get this done. Yeah.
So here, I would say, just in these closing slides, you can see that what we've done is we've brought in all of our patients from Patient Day, and we've tried to capture them. So we've captured them doing a bunch of common functional movements like rolling, sit to stand, getting off the floor. So that
Ready when you are.
Faculty and students will be able to practice and see normal from so-called abnormal or dysfunctional or movement faults, movement impairments, and that we as faculty would also be able to have this resource as a way to take the learning further, to have active discussions in the classroom. So that's just really a glimpse. We've captured traumatic brain injury guy, Parkinson's guy. There's another stroke person, doing all of these common functional movements. And so this particular app, we're actually, Tina Stokman, Adam Marquette, and I, as well as Kathy, we are trying to gather videos of neuro patients so that faculty will be able to have a repository that everybody can utilize to take the learning. I mean, the learning, I think, is heavily enhanced by context. And context comes from beginning to be able to see real patients. Everybody knows the burden of a patient day. What if patient day could occur asynchronously? What if there was a checklist of key movements or key phases of rolling or sit to stand that a student could now observe and play out asynchronously while they're learning to apply this movement analysis process? So I think that that is kind of where we're headed. I would love to hear your thoughts, suggestions, or comments.